Hi there, this is Dr. Evan Osar with Fitness Education Seminars. Welcome to this edition of Fitness Insider, where we'll look at a corrective exercise strategy to improving hip function. If you missed part one on the shoulder, feel free to check that out after you've watched this one. So why do so many of our clients have hip pain and hip dysfunction that relate to the over 1 million hip and knee replacements and the over 1 million orthopedic surgeries on the low back, hip, and knees that occur every year in this country? Well, the image to the left depicts three of the most common situations you'll see with your clients and clients that have dysfunctions of the low back, hip, and or knee. The gentleman in the far left doesn't get enough anterior pelvic tilt, either because of a stiff posterior capsule, short hamstrings, and or inhibited hip flexors. This causes him to overflex through both his lumbar spine and his thoracic spine. And again, it's a common cause of low back issues. The gentleman in the middle has that classic no-butt looking syndrome. He overuses hip gripping type strategy, and he drives his hips forward in the acetabulum. You can see he has well-developed hamstrings and calves, but no gluteal mass. And he also has lumbar spine flexion, which is also related to this condition. The female in the far right image, she doesn't get enough spinal extension and or posterior pelvic tilt and hip extension. So therefore, she'll have her own issues, and she'll compensate through her shoulder biomechanics because the hip and the spine are not helping her out so well. So why do so many of our clients have these issues? Well, we know surgery will drive changes. We know injuries will drive changes. We know improper cueing and posture drive issues. But a lot of these issues can be related to clients sitting all the time and the inhibition of key stabilizers and as well as prime movers. So in this webinar, we'll take a look at how do we improve hip function using a corrective exercise approach to improving function. Common hip problems, tight hip flexors, we talked about that in a previous webinar. If you missed the one on psoas, check that out. And as we showed or demonstrated, that most of our clients that have tight hip flexors have tightness of the superficial hip flexors. They actually have inhibition of the psoas and deep stabilizers. IT band problems and knee problems related to running and cycling and things like that can often be related to hip dysfunction, as well as low back pain. And a sacroiliac joint pain can be related to poor function of the hips. And these can all be related to, even though they all seem like different issues, they can all be related to how well we centrate our hips. In this image, you can see the client's pelvis shifts out to the left, or her right, our left. Her knee goes into abduction and internal rotation, and her lower leg goes into external rotation to help create stabilization. And it's really the lack of the coactivation around the hip joint that creates a lot of these biomechanical changes. And we really see it show up when we have to go into unilateral stance during gait and or especially higher level patterns like running. So how do we change these patterns? This also creates situations where we have an anterior hip syndrome. And that's often a cause for some of those situations that we just discussed because of different stabilization strategies, because we're trying to make up for what our body or our nervous system is not giving us. So for example, the gentleman to the left, he will use an over butt gripping strategy. These patterns are set up because he's overusing his superficial glute max to stabilize his pelvis and his hips, and or he's been cued to overgrip his hips, so he'll also drive the hip forward in the socket, which creates this divot right here. Okay, this woman to the right, she'll overactivate her abdominal wall, so she's an abdominal gripper. She'll overactivate the rectus abdominis and the external obliques, creating that big indentation, and will also drive her pelvis into a posterior rotation, and she has a little bit of hip gripping as posterior hip gripping as well. Both these situations require different strategies, but very similar patterns of dysfunction that we see in our clients with hip dysfunction. So what's our corrective exercise strategy checklist of things we need to improve? One, we have to improve activation of the deep stabilization system, specifically the psoas, the deep hip rotators, and even the deep medial fibers of the glute maximus. We have to teach our client how to centrate their hip better during their hip patterns, and we'll show you a couple examples of that. And then we have to teach the client how to integrate these into higher level patterns. So activation of the deep stabilization system. The side lying isometric position is a great pattern to connect the entire left side of this individual's body. We're going to create stabilization around the scapulothoracic junction, the thoracolpelvic canister, as well as into the hip. He's going to push that knee, this left knee, down into the floor, almost as if he's going to rotate the foot up towards the ceiling. So the foot comes up slightly, the knee goes down to activate the hip flexors and hip abductors and hip rotators. At the same time, he's going to do similarly with his upper body. He's going to push the elbow down, which is going to drive the scapula down and around the thorax to help create stabilization of this entire left side. He's going to hold this isometric position for 5 to 10 seconds, and he's going to repeat it for about 5 repetitions. So again, this helps to set up the stabilization patterns that we need for loading. Again, the hip external rotators, the hip abductors, and the deep hip flexors, specifically the psoas and portions of the iliacus as well. Once he's able to activate these structures appropriately and start the process of centration better, then we teach him to go up onto one knee and one elbow. The reason we use the supported knee rather than just a straight out plank is because by using the knee as your contact point, it drives better centration and feeds into the hip better than using that straight leg pattern, which sort of bypasses the hip itself and takes the stress right into the shoulder and trunk. We want to get the hip tied into the trunk, tied into the ipsilateral shoulder, and that's why the modified side plank is a great position to do that. And as he gets better activated and better control in that position, he can even lift his right leg and support himself completely on his left side. Even though it looks like a really easy pattern, it's actually a really challenging pattern when done with proper stabilization and a real long spine position. Once he's able to do that, or along with that, we'll also work on a deep squat. I should say just regular squat. Supported squat, where he's thinking about keeping and maintaining a long spine and sitting back into his hips as much as he can while relaxing the superficial hip flexors. So again, he maintains thoracolpelvic stabilization and alignment, then he wants to sit back into his hips so he can activate the deeper hips, so the deep hip complex of both the deep hip abductors, both the glute medius and minimus, as well as the deep medial fibers of the glute maximus. He sits back. The support allows him to sit back without worrying about stabilization as much, and he's able to maintain alignment, and he can really think about relaxing the anterior portion of his hip, which is usually very overactive in these clients with the anterior hip syndrome. Now we're going to teach him how to reestablish hip centration in some classic corrective exercise patterns. On the left, we're going to use a bridge, and the reason I like this pattern is because I can really teach them how to hip hinge in a supported position. So again, I want the client to be long through their spine. I want them to be able to posteriorly rotate and upwardly rotate the scapula, and that's what we covered in the last webinar. I want the anterior rib cage to be connected to the pelvis, and I want them to drive motion through the glutes, but not overactivate the glutes to create that divot or that lateral gripping that happens through the outside of his hip complex. So I want him to lift up and use the glutes, but not drive the pelvis so far up that he's overextending through the thoracolumbar junction. And I want to make sure he's not abducting the legs or externally rotating the legs as he does this. I want to make sure his legs remain parallel. In the image to the right where the woman is performing a split squat, I want her spine to remain long. I want her to place one hand in front of her hip, one hand behind her hip. I want her to sit back into her posterior hand and relax the front of her hip. I want her to be able to centrate that hip by sinking it back into the socket, especially for those clients who have that anterior hip glide and or overactivation of those superficial hip flexors. This is a great pattern to teach the dissociation of the femoral head within the acetabulum while being able to utilize and activate those deep glute fibers. Once we've done this, now we can teach them how to integrate this into the fundamental patterns of squatting and forward reaching. Again, with a squat pattern, I want to teach him how to sit back as he's holding the resistance, whether it be a ball, medicine ball, dumbbell, and even a barbell. As he does a forward hip hinge in a single leg pattern, I want him to teach him how to anterior pelvic tilt while maintaining neutral spine positioning and while maintaining alignment of the hip, knee, ankle, foot complex. He's going to create rotation right around that hip femoral acetabular junction, and he's going to maintain a nice long spine as he does that. And then I want him to pull with the glutes and the hamstrings back to the neutral position, but not drive the femoral head forward in the socket. Conclusion. We want to identify one of the key things to a lot of our clients' hip dysfunction, and that's the anterior hip position. And if we can teach them how to improve that both through an awareness, cueing, and corrective exercise, we'll be able to help a lot of our clients improve function. We want to isolate out some of the muscles and patterns, positions that help to centrate the hip better. We use a modified side plank as one of the patterns. We can also use the bridge and supported squat as well as the split squat to help improve this function. And then we teach the client how to integrate this function, the centrated hip position, back into their fundamental patterns, whether they be squatting, lunging, stepping, walking, and running. This is Dr. Evan Osar with Fitness Education Seminars. I hope you enjoyed this session of Fitness Insider. I hope it served you well in helping your clients improve their hip function.